Even though according to your schedule, it's supposed to be Dr. Abdul, he took the lecture on Sunday, apparently, in the afternoon, and he completed his lectures yesterday morning. And I will now do the autonomic nervous system. I believe you had one lecture by Dr. Shahid Akun about the structure of the autonomic nervous system. I will look at the physiology of the autonomic nervous system. I must admit at the outset, it's not a very easy thing to understand, but I have tried to make it as manageable as possible. And I've kept it so that you just do what's on the slides and you are okay. You don't need to go and read a neuroscience textbook. You'll do that next year when you do neuroscience in second year. Is that okay? Good. Second thing, before I start the lecture, I just want to say one thing about attendance. I fully understand that there are about 400 of you sitting in the room, not right now, because there are 200 that are waiting in front of Dunkin' Donuts. There are about 400 of you that are in the room. I fully understand that there might be a wireless whatever story to it. I fully understand that the app does not work. I would suggest one thing though. Please try and sort out your attendance problem before I leave here. Is that okay? Do not send me a dozen emails about your telephone, what worked, what didn't work, how it should, whom should you see, and so on and so forth. All right? I would like that you complete your attendance before I leave. Don't send me an email. I'd rather spend my time preparing a lecture than repeatedly opening Moodle and correcting people's attendance. Is that okay? Yes? Thank you. All right, let's start with the autonomic nervous system. As I said at the beginning, it can become very unwieldy, very lots of information that you have to kind of retain about the autonomic nervous system. Now, before I begin the autonomic nervous system, I want to go back to something that Dr. Shams did with you. He looked at skeletal muscle, which you know is a voluntary muscle. A voluntary muscle is innervated by a motor neuron, an alpha motor neuron. That motor neuron comes to a muscle, and as the word suggests, voluntary, you can make that muscle contract when you want to. You have control over that muscle. When you want that muscle to contract, action potentials will come down the alpha motor neuron. It will get to the neuromuscular junction, and all of the things that Dr. Shams told you happens at that neuromuscular junction, and then that muscle contracts. We call that a somatic, S-O-M-A-T-I-C, a somatic innervation, meaning you have control over it. Okay. There are other kinds of control in your body that are unconscious. They are happening right now. But you are not controlling them. Okay, there are some of you who are drinking coffee. As that coffee goes down your esophagus, the esophageal sphincter will relax and allow the coffee to go into your stomach. And then it will constrict again. That's an autonomic response. Okay, now, there are some things of the autonomic nervous system, again, that is much too involved. But we will just look at the basic things, and I'll tell you what are the important bits, at least at the first year level for you. Why are you doing this? You are doing this because smooth muscle is under autonomic control. Okay? In other words, for smooth muscle to contract, you have a neurotransmitter in much the same way as skeletal muscle. Smooth muscle contraction is due to a neurotransmitter of the autonomic nervous system. Okay? And when that smooth muscle is stimulated by things like norepinephrine or epinephrine, those are the neurotransmitters, that's when it will contract. Now, how does that thing work? And that's today's lecture. So let's move ahead. These are the things I will look at. Let's try this. I do not expect anybody in the room to know the answer. So I will put this question back up at the end of class, because I'm of the opinion that you do not have enough knowledge right now to answer this question. But let me read the question. It says, a patient with newly diagnosed schizophrenia. That's unimportant. Okay? Newly diagnosed schizophrenia is given chlorpromazine. Now again, that drug is unimportant. Chlorpromazine is an antipsychotic drug. It's given to people who kind of have this problem. It is a drug that has, amongst other effects, in other words, antipsychotic, it has a moderate anticholinergic activity. Now, you might know what cholinergic means. It's related to acetylcholine. Okay? So that is the question. And it says, which of the following is an expected side effect of this medication? So we're not really worried about the schizophrenia and the psychoticness. We are worried about the side effect. Okay? So as you're going through the lecture, you want to answer this question. So let's get started. Again, as I mentioned, the autonomic nervous system is under, how could I put this, unconscious control, if you want. So we have two pathways that are controlling our body. Two efferent pathways. Efferent meaning coming out from somewhere in the central nervous system towards our cells, towards our muscles, towards our glands, and so on. And these efferent pathways are the somatic motor system, which Dr. Shams talked about. And today we will talk about the autonomic nervous system, okay, which is involuntary. Okay, you are secreting enzymes and secretions of your GI tract without you knowing. Again, the autonomic nervous system is distributed to organs within your body, like the abdomen, in other words, the stomach and the pancreas, and so on and so forth. So I put a general term, visceral organs, and that could be blood vessels, glands, okay, the heart, and so on. The cardiovascular system, exocrine glands, and it is without conscious control. Now, the functions of the autonomic nervous system, one is for homeostasis, for example, regulation of blood pressure. All right? And second one, so that you control the response to being scared or the response to being totally relaxed. All right? So stress responses, okay, or exercise. And you may know this, the fight or flight response, that would be for the sympathetic nervous system, and for the parasympathetic nervous system, it's called the rest and digest response. Again, integration of visceral function so that you can have digestive system, your digestive system working at a time when hopefully you're not running, where you need more blood towards skeletal muscle. Okay, so you're integrating this function There is one more part. So you have the autonomic nervous system made up of sympathetic and parasympathetic. There is one more part to the autonomic nervous system, and I am not going to say anything about it today. You will do this in your next block, the GIT, and that is called the enteric nervous system. Now, when you do smooth muscle in histology lab, sometimes they will show you a slide of the small intestine, and between the two layers of the circular and longitudinal smooth muscle, there is a layer of neurons. Okay, it's called Meissner's plexus or Auerbach's plexus, and that is what this enteric nervous system is about. Again, it is autonomic. So, please listen attentively. Try and get as much as you possibly can right here. So if you look at the autonomic nervous system, let's start at the bottom. Can you see the blue box? Yes? That is the somatic one. That's the voluntary control. Everything above is the autonomic nervous system, as it says here on the left-hand side. So there's my motor neuron coming from the ventral horn of the spinal cord. It'll go to a muscle. I have a synapse. I release acetylcholine. It binds nicotinic receptors on the muscle, and the muscle will contract eventually. Okay, we're done with that. The autonomic nervous system is made up of two parts. The rest and digest one, and that would be the parasympathetic nervous system. Where do the neurons come out of the central nervous system for the parasympathetic nervous system or the parasympathetic division? They will come out from the cranial or the cranial nerves, as they are called. Cranial nerve number 3, number 7, number 9, and number 10. And they will come out at the sacral region, all the way down at the bottom of the spinal cord. That's why the parasympathetic is called craniosacral. Now, when they come out of the central nervous system, in other words, the spinal cord, they will give off a neuron to this structure. See the structure? It's called a ganglia. All the cell bodies for this, what says post-short, all the cell bodies for this neuron or axon is found inside this ganglia. And there's a difference. The pre-ganglionic fibers of the parasympathetic nervous system tend to be long. Can you see the word? In other words, it leaves the spinal cord and it goes all the way, almost near to where the organ is. Therefore, it is long. Whereas the post-ganglionic parasympathetic neuron is short. And that's the difference between the parasympathetic and the sympathetic. The sympathetic has short preganglionic but long postganglionic neurons. So let's go back to the parasympathetic. Two things I want to point out. First, the neurotransmitter that is released between the pre and the postganglionic, in other words, in the ganglion, is acetylcholine. And there's it down here, the star moved, okay? So all the stars are acetylcholine. That will be called the preganglionic neurotransmitter. The postganglionic neurotransmitter, near the effector cell, there's the effector organs, the smooth muscle glands and so on. The postganglionic neurotransmitter is also acetylcholine. No exceptions. Let's look at the sympathetic. Again, the sympathetic leaves the central nervous system or the spinal cord, where it leaves in the thorax and the lumbar. Therefore, it's called thoracolumbar, T1 to about L2, L3. So it leaves the spinal cord. Again, it goes to a ganglion, but this time, all of the ganglia are on the side of the spinal cord. It's called the sympathetic chain. And because the sympathetic chain is right next to the spinal cord, the preganglionic fibers tend to be short. The neurotransmitter is still acetylcholine, and they attach to nicotinic receptors on the postganglionic cell bodies. Now, because this is right close to the spinal cord and the organ is far away, the postganglionic sympathetic fibers tend to be long. All right? And because they are long, they have to go all the way from the sympathetic chain all the way to the organ. And there's a couple of differences you need to know now. All of the postganglionic sympathetic neurotransmitters are all norepinephrine. Can you see NE? Yes? Yes? With two exceptions. Number one, postganglionic sympathetic neurotransmitter to sweat glands, to thermoregulatory sweat glands. Those are the sweat glands we have on our forehead and so on. When it's hot, you see the sweat. That one is cholinergic. In other words, it releases acetylcholine. One more difference. The postganglionic neurotransmitter to the kidney is a dopamine receptor, so it's called D1. All the others are for norepinephrine. One more exception. So all of this connection is between two neurons, 1, 2, 1, like that. With the exception, the adrenal medulla. Can you see the medulla? The adrenal medulla is a sympathetic ganglion. It's like a sympathetic gland, if you want. It only has a pre-ganglionic fiber. There is no post. And it is releasing acetylcholine at that junction. Okay? Now, what does the adrenal medulla release when the chromaffin cells are stimulated? It releases epinephrine, about 80% epinephrine, and about 20% norepinephrine. And that's what you see here. Last thing before I move off the slide, and this is important. This is important. You notice that all of the postganglionic neurotransmitters in the sympathetic nervous system use norepinephrine. Now you might ask me, okay, how come a single neurotransmitter can have two different effects? For example, how come norepinephrine on a blood vessel can make the blood vessel constrict, but norepinephrine on a blood vessel can also make the blood vessel relax or vasodilate? And this is where it becomes important. So the effect is not due to the neurotransmitter, it's due to the receptors that are found on the effector cells. And the sympathetic nervous system has alpha and beta receptors. And there's an alpha 1, alpha 2, beta 1, beta 2, beta 3. And I'll come to those later. Now you notice there's quite a few things that are going on here. Okay? And we can ask lots and lots of different multiple choice questions just with looking at the exceptions. just take this one step further. I put those things, and I put here very important slide, because this is showing you diagrammatically, and I talk through it. This has it written down. So look, the origin of the preganglionic fibers in the sympathetic is between T1 and L3, thoracolumbar. Whereas in the parasympathetic, it is cranial, sacral. Okay? And cranial nerve coming from mostly the brainstem region, the midbrain, the medulla, and the pons. Cranial nerve number 3. Cranial nerve number 7. There's a name for number 3. It's called the oculomotor nerve. Number 7 is called the facial nerve. Number 9 is called the hypoglossal nerve. And number 10 is called the vagus nerve. Okay, so that's the difference. Again, where is the ganglia? What ganglia? This thing here, can you see? Where is the ganglia for the sympathetic nervous system? It's right next to the vertebrae. That's why it's called paravertebral. That is why the preganglionic fiber is short. Whereas for the parasympathetic, it's closer to the organ. Therefore, the preganglionic parasympathetic neuron is long. The length of the preganglionic fiber is short, then it's long. The postganglionic fiber is opposite. I put the most important thing in red. Look at the bottom. Where do they go to? They all go to the same place. Smooth muscle, glands, GIT, and so on. Again, the neurotransmitter, the preganglionic neurotransmitter for sympathetic nervous system is acetylcholine, attaches to nicotinic receptors. Again, for the parasympathetic nervous system, it's the same thing. Postganglionic neurotransmitter in the effector organ, or the postganglionic neuron neurotransmitter. In the case of sympathetic, it's norepinephrine, with the exception of sweat glands, which is muscarinic. And for the parasympathetic, it is acetylcholine. Lastly, receptor types. For the sympathetic, I told you alpha 1, alpha 2, beta 1, 2, 3. For parasympathetic, it is cholinergic, muscarinic receptors. Now, same thing. Now I am showing you what are the effects of the autonomic nervous system. So let's start off with the sympathetic. Where is it coming from? It's coming from T1 to about L2, L3. That's all the green. Can you see all the green? Yes? Again, it goes to the eye and it vasodilates the pupil. All right, it vasodilates the pupil. Now, the way to think about this is like blinds. You know what are blinds? Yes, windows, we have blinds, yes? All right. And sympathetic nervous system, under the influence of norepinephrine, will make the blinds to open. That means the pupil will enlarge, they dilate. And why does this happen with the sympathetic nervous system? Because the sympathetic nervous system is flight or fight. You need more light into your eyes so you can start making decisions. Okay? It inhibits salivation. Sympathetic nervous system. I'm not going to read the entire list. I'm just going to deal with the major ones, at least the ones for now. Increases heart rate, okay, through beta 1 receptors. Norepinephrine will increase heart rate. It will dilate the airways. That is why, if anybody who has asthma in the room, when you take your inhaler, if you look at the thing, what it has in it, it either has a adrenergic agonist, okay, which will dilate the bronchioles and the airways, so you can get more air into your lungs. Okay, I'll leave stomach for a minute. I just want to go down to, where's blood vessels? It doesn't say, the next slide will say. And again, I can also have down here L1, 2, and 3, L1, 2, and 3. And where do those go to? They generally go to the lower end of the GI tract, the lower end of the descending colon, the rectum, and then to the genital organs, or the reproductive organs. Okay? On the other hand, if I look at the parasympathetic now, and there's the effect, notice you have opposite effects. Can you see? The parasympathetic will constrict the eye, or the pupils, at least. Will increase salivation, slow the heart rate down, and constrict the airways. Okay? Now, again, at the sacral end, it goes to the bladder, okay, and the male and female reproductive organs as well. All right? Now, one thing before I go off the slide, and please just understand this. Because you're seeing this opposite effect of the two kind of autonomic nervous systems, or the divisions, please do not consider them as antagonistic. Rather, consider them as working together to attain a certain spot. Okay? In other words, they are reciprocal to each other. All right? It's not like one works and the other one is relaxing and the other one works and so on. Doesn't work like that. Okay? They are reciprocal, they're not antagonistic to each other. Okay? So, in other words, the degree to which the pupil is open depends both on parasympathetic and sympathetic. So, if it is open wider, that means the sympathetic is working more. Okay? If it is constricted more, that means the parasympathetic is working more. You follow what I'm getting at? Okay? Okay, now, Dr. Shams told you, you have a motor neuron that comes to a neuromuscular junction. In other words, there is a specific place on a muscle fiber where that neuron will come to. Is that the same situation with an autonomic nerve? No. So there's a smooth muscle. All right, there's an autonomic neuron. It comes along, and at the end of the neuron, what it does is it makes these bubbly-looking structures. These bubbly-looking structures are called varicosities. Inside the bubbly-looking structures are the neurotransmitters. Okay? So it's not at one spot and then everything spreads in the muscle. Doesn't work like that. You know, smooth muscle, at least the example that I'm using here, does not have T tubules. Okay? Plus, smooth muscle can be multi or single unit contractions. So if you had a multi-unit contraction, that means every one of those fibers needs to get an autonomic supply. Again, these varicosities, these bubbly-looking structures, there's the neuron with the myelin on it, okay? Has the neurotransmitter in it, whether it's acetylcholine or whether it is norepinephrine. Again, the neurotransmitter, there is no really a synapse kind of region, okay? The neurotransmitter can diffuse away, it can be metabolized by enzymes. Monoamine oxidase will break down norepinephrine. Okay? Acetylcholinesterase will break down acetylcholine. It's actively transported into the cells and it's degraded by these kinds of things. Okay. There's one of those varicosities. So step number one, there's the varicosity. I get an action potential coming in, calcium goes in, the vesicle comes, binds, releases the neurotransmitter. and it goes over to the muscle. So if this was one that we were looking at the muscle, it'll go over to the muscle, attached to an adrenergic receptor, alpha 1, alpha 2. Remember those? Okay, attached to an adrenergic receptor, activate G protein, and now you have an effect, either of contraction or relaxation. And what happens to that neurotransmitter? It can be taken up back into the varicosity, so this transporter here. It can be degraded by an enzyme, or it can diffuse away into the blood. All right, and those are the things that can happen to that norepinephrine or epinephrine and so on. So if your adrenal gland is releasing epinephrine, it'll come through the blood, diffuse over here, and have an effect on the cell. So let's look at the organization of, we looked at the general thing before, quickly look at the sympathetic nervous system. Again, T1 to L2, L3. Here, so T1, okay, there's the pre-ganglionic fiber, there's the sympathetic chain. Can you see the sympathetic chain? And coming out of that ganglion would be the postganglionic fiber. So if I take one of them, let's just take this one, it's coming out and it's going to the trachea. Okay? So that would be the postganglionic neuron. Now, you may ask me, if the sympathetic nervous system is controlling the eye, and the preganglionic fiber only comes out at T1, how does the neuron come to the eye? Well, it comes out at T1, and then it will go up the sympathetic chain. It will synapse, and then give you a postganglionic fiber to the eye. Or, you know, to the salivary gland or whatever it is. And the same thing happens at the bottom. It comes out at L3, goes down towards the sacral region, and then goes to places like the lower GI tract and the genital organs. Again, thoracolumbar, preganglionic fibers will release acetylcholine, that's inside here. All right. Again, one group of preganglionic fibers does not go to the sympathetic chain. It goes straight through and it goes to three ganglions: the celiac ganglion, the superior mesenteric, and the inferior mesenteric ganglion. So they don't go inside here, they come straight to these ones. And one more, you have a preganglionic fiber that generally goes straight from the spinal cord into the adrenal medulla. The celiac, the superior and inferior, are called paravertebral ganglia because they're not sitting right next to the spinal cord. They are called paravertebral ganglia. Sympathetic postganglionic neurons are all adrenergic. In other words, they are stimulated by noradrenaline and epinephrine. Except, which one? Which one? Good, thermoregulatory sweat glands. And those are cholinergic. Again, same thing, these are the receptors. So there's an alpha-1 receptor. It's the most dominant type of receptor for the sympathetic nervous system on target tissue. It's found in smooth muscle, GI tract, and so on. It is excitatory. In other words, it will make smooth muscle to constrict. Okay? How it does it is through phospholipase C, increasing IP3, calcium release from the ER, and now the muscle can contract. Alpha-2 receptors have the opposite effect to alpha-1. So same neurotransmitter, but the opposite effect. And it is mostly found on the preganglionic neuron. And what does it do? It suppresses the release of norepinephrine. So less norepinephrine means less stimulation, therefore relaxation. Beta 1, found mostly in cardiac muscle. They are excitatory, so they will increase the heart rate, they will increase heart contractility, okay? They will decrease the time of delay in the AV node, atrioventricular node. That will make the heart rate become greater. Beta 2 receptors are found in smooth muscles, and again, they are inhibitory. So alpha 1 is excitatory in smooth muscles or arterioles. Beta 2 is inhibitory in smooth muscles. And lastly, B3, mostly found in adipose tissue, where it increases fat breakdown. There's the adrenal gland again. There's the kidney with the adrenal gland sitting on the top. There's the adrenal gland. It has a cortex, which releases 3 hormones: aldosterone, cortisol, and male and female sex hormones, dihydroepiandrosterone. You don't need to know that. But this middle region, where you have the medulla, is what will release. Again, there's the preganglionic neuron. Okay, sympathetic comes here, and then you release epinephrine, and epinephrine can now go into the blood and bring about constriction and so on and so forth. There is a cancer of the adrenal medulla called pheochrocytoma, where there is an excessive release of epinephrine, all right? And generally that will end up with hypertension. The patient will have hypertension, tachycardia means a high heart rate, and then diaphoresis. In other words, they sweat a lot. Quickly look at the parasympathetic nervous system. Again, cranial, this is brain or midbrain. Remember I told you, medulla pons, okay, midbrain medulla pons. There are nuclei there, okay, Edinger-Westphal nucleus, and they give off these preganglionic neurons of the parasympathetic nervous system. Again, cranial nerve number 3, oculomotor, cranial nerve number 7, facial, cranial nerve number 9, hypoglossal, and cranial nerve number 10, the vagus. There's another place these nerves come out of, and that will be the sacral region. Again, they go to places like the lower GI tract, the bladder, and the genital organs. Again, preganglionic fibers for the parasympathetic are cholinergic. Postganglionic are also cholinergic, no exceptions. When a postganglionic fiber is stimulated, it releases acetylcholine. They also release other substances, for example, vasoactive intestinal peptide. Okay, and this will cause the GI tract to relax. Okay, they also release nitric acid, NO, which is a muscle relaxant, or it prevents muscles from contracting and therefore causes vasodilation. About 75% of all parasympathetic fibers are in the vagus. See, the vagus goes to the heart, it goes to the lungs or the bronchioles, goes to the GI tract, and so on. And only the other 25% are in these ganglia up here. And they go to the eye, the salivary glands in the mind. Again, sympathetic, generally fight or flight. In other words, you have an increased heart rate, increased blood flow, so you're going to decrease blood flow to the GIT and to the skin. You're going to increase blood flow to the skeletal muscle to run away if you want. Dilates the bronchioles of the lung, so you get more air and you can get more oxygen should you want to run away or start a fight. Increase the heart rate. Dilates the pupils, as I told you earlier on. Okay, and it makes the lens of the eye rounder so you can see further away. In other words, distant vision. Okay, vasodilation of coronary arteries, so your cardiac muscle gets more oxygen. All right. Look at the parasympathetic one. It's kind of opposite now. Dilates blood vessels to the GI tract because you're going to bring about digestion. Constricts bronchioles, so you can move the blood to the GI tract. The vagus of the thoracic spinal accessory nerves decrease heart rate, in a relaxed state, obviously. Again, accommodation causes constriction of the pupils and contraction of the ciliary muscles. All right, so now you can see close by or near vision. Stimulates the salivary gland. Okay, brings about peristalsis. The peripheral nervous system is involved in the sexual functions like erection and so on and so forth. Now, look at, can you see this guy there? Yes? Now, let's for an argument, assume that the blood pressure, I can't see this thing. There we are. How do I choose a color? Let's make it red. So there we are. Let's say the blood pressure is going up. All right. So the blood pressure is going up. If the blood pressure is going up, why will the blood pressure be going up? Because the arterioles are constricted. Okay. If the blood pressure is going up, that will be sensed by the carotid, the aortic, and the carotid baroreceptors. That information goes to the medullary cardiovascular center. That will then stimulate parasympathetic and sympathetic. Now, what will then happen? You will get these neurons coming to, remember, vagus to the heart. Okay, vagus to the heart, increase parasympathetic stimulation, you slow the heart rate. Okay, you decrease sympathetic stimulation, that will also slow the heart rate, but it will also decrease the contractility in the ventricles, and the effect of that is to decrease the pressure coming out of the heart, and now the pressure comes back, hopefully, to normal. Okay, and that's called the baroreceptor reflex and how they work with each other. That's why I said they are not antagonistic. They work with each other to bring about like a homeostatic level to, in this case, or at least my example, regulation of blood pressure. Now, I found a table with all of these organ systems. So the heart. Sympathetic will increase the heart rate, as it shows you. Which receptors? B1. Okay? Whereas parasympathetic will decrease all of those functions. Which receptors? Muscarinic. Cholinergic muscarinic receptors. And I put that here for you, because there aren't any exceptions for the parasympathetic nervous system. Vascular smooth muscle, alpha-1 will cause constriction, beta-2 will cause dilation. Same neurotransmitter, no epinephrine. Okay. I'll just do bronchioles, one more, bronchioles. Alpha-1, sympathetic beta-2 will cause dilation of the bronchioles, so more air gets into the lungs, whereas parasympathetic will cause constriction. The one exception is D1. That goes to the kidney to release renin through the sympathetic nervous system, and there you use dopamine. The other exception is sweat glands, where you are using cholinergic, in other words, acetylcholine. sympathetic nervous system using acetylcholine. There's the difference between sympathetic and parasympathetic nervous system. You can look at this at home. The origin of the ganglia, okay, thorax and lumbar. I've said that a dozen times now. Okay, location of the ganglion, the region from which the neurotransmitter is released, both are very positive. In this case, it's norepinephrine. In this case, it's acetylcholine. Obviously, there's an exception here, and that's the sweat glands. Uptake is back into varicosities using a transporter. Most of the receptors are adrenergic. Here they are cholinergic or muscarinic. And here you have alpha and beta, and here you have muscarinic. Now, if you look, you have, there's my sympathetic neuron coming out, or preganglionic coming out at T1. It's going to the sympathetic chain, there's the chain, and then it's making my way upwards. And this is called the superior cervical ganglion. Where does it go after that? It then goes to the eye. Now, if anything happens to this thing at this spot, anything, remember the sympathetic nervous system dilates the pupil, remember that? Yes? If the patient comes in looking like this, can you see the eye? Can you see it's constricted? Yes? So, constriction of the pupils, smaller, the eye is pushed in, compare this side, okay, to this side. Okay, that's what we call anophthalmos, all right? Drooping of the eyelid, because the sympathetic nervous system also stimulates the muscles on the eyelid. So you can open the eye. Again, if there is dryness on one side of the face, on that side, all of that is an indication that something is gone wrong with the sympathetic nervous system here. In other words, in the superior cervical ganglion. And this is called Horner syndrome. All right. One more thing, last slide. Sorry, I took a couple of minutes of your time. There's a preganglionic neuron. There's the effector. You release neurotransmitter. There we are. It's coming out here. It'll bind to its receptor and bring about an effect. Now, there are certain drugs that have effects at this spot. For example, amphetamines will increase norepinephrine release from the ganglia. Cocaine will inhibit the transporter taking the norepinephrine back into the postganglionic neuron. And you can look at all the other drugs. I'm not expecting you to know these drugs. You can do this when you come to third. What you should know, however, is if I did give you this drug, I'll tell you what it does. Okay? But you must know the effect. So if you get ephedrine, it increases norepinephrine, and I'll tell you that in the question. Then you must know what the effect would be. Can we come back to the question? Anybody want to have a go? Yes, sir. Good, wonderful. It's C. Okay, it is C. And there's the reason for the C. Okay, thank you.